Hi everyone, welcome back to another part of our clinical case scenario series. So let's begin our today's lecture. So here is the scenario number 31 on your screen. A patient arrives at the initial evaluation with complaint of ankle pain that began with the sudden onset after the patient jumped off the couch. The Thompson test yields a positive result. So this is the indicative of which of the following? Option A, high ankle sprain. Option B, lateral collateral ligament sprain. Option C, ruptured Achilles tendon. And the option D, navicular fracture. And the correct answer is option C, ruptured Achilles tendon. And here we have the explanation. Thompson test is a special test for Achilles tendon integrity. The positive test indicate the Achilles tendon rupture that typically happen when the person do a quick movement. Let's move to another scenario. A true leg length discrepancy may be differentiated from the sacroiliac joint contribution by performing the supine to long sit test. When a patient has a right anterior innominate, option A, the right leg will appear shorter in supine and the same length in longer sitting. Option B, the right leg will appear longer in supine and the same length in long sitting. Option C, the right leg will appear shorter in supine and longer in long sitting. And the option D, the right leg will appear longer in supine and shorter in long sitting. And the correct answer is the right leg will appear longer in supine and shorter in long sitting. Let's see the explanation. If the leg length discrepancy is due to the sacroiliac joint, so the supine to long sit test will help you indicate the leg length discrepancy. If the patient has an interior innominate, it means that the leg that looked longer in the supine will become shorter in sitting. And if the patient has the posterior innominates, this means that the leg that looked shorter in the supine will become longer in sitting. So let's move to another scenario. A patient presents to the therapy with moderate pain in the bilateral distal lower extremities. He reports that the pain is better when his feet are elevated. So during the evaluation, the therapist notes that the skin was prone discolorization and flaky and dry. Pedal pulses are normal and there is a grade 2 pitting edema bilaterally, so which is the most likely cause of the potential leg pain? Option A, arterial insufficiency. Option B, venous insufficiency. Option C, diabetic peripheral neuropathy. And the option D, bilateral calf strain. And the correct answer is option B, venous insufficiency. And here we have the explanation. In the arterial insufficiency, there is a severe pain during the night, ulcer on the lower third of the leg, diminished pedal pulses, decreased skin temperature, shiny skin with hair loss, and there is a pain during leg elevation. On the other hand, in venous insufficiency, this is identified with mild to moderate pain, normal pedal pulses, increased edema, dry and flaky skin that has normal skin temperature, brown discolorization of the skin, and during leg elevation, there is decrease in pain. Let's move to another scenario. In the initial evaluation of the patient with the back pain, the patient describes symptoms including pain that radiates to the dorsal aspect of the foot, accompanied by tingling. On assessment, there is a weakness in ankle dorsiflexion. So, which is the most likely cause of the patient's back pain? Option A, nerve root irritation at the lumbar level of 4 to 5. Option B, nerve root irritation at L5 to S1. Option C, postural strain. And option D, compression fracture. And the correct answer is option A, nerve root irritation at the lumbar level L4 to L5. So here we have the explanation. This dermatomal and the myotomal pattern is one of the L4 to L5 distribution. So therefore, the irritation of the nerve root would be the most likely cause of these symptoms. So the rapid pain from the L4 to L5 level usually stays within the lower back and is typically felt as a dull ache. So the back may be more stiff, and depending on the type and severity of underlying cause, the L4 and L5 motion segment may cause the lumbar radicular pain of the L4 or L5 spinal nerve, which we also call as sciatica. Let's move to another scenario. You are providing the wound care for the recent adult in burn unit admission. The patient presents with a burn covering the left anterior leg, anterior chest, and the left anterior arm. So what percentage of the patient can you estimate is a burn area? Option A 50%, option B 38.5%, option C 31.5%, option D 27%. And the correct answer is option C 31.5%. And here we have the explanation. As you can see in this table, on the basis of rule of 9, the left leg would be estimated 9%, anterior chest would be 18%, and the left arm estimated 4.5%. And the total of all these percentages is 31.5%. So that's all for today's video. We are going to cover the next scenarios in our upcoming lecture.